Can other people hear him?
I cannot hear him.
How about that? Does that work?
Yes.
There we go. Teams is not something that works well with my computer, so I should have anticipated it. I only took a look at the link this morning, but with the help of tech support, here I am. Thanks so much for your patience.
Thank you so much for being here.
For figuring it out and for your persistence in joining us this morning. Everybody, we want to introduce you to Dr. David Rosmarin, who is the Director of Spirituality in the Mental Health Program at McLean and Associate Professor of Psychology in the Department of Psychiatry at Harvard Medical School. As Dr. Kaufman was just telling you, he developed this Spirit program for use in inpatient settings, and he's going to tell you more about it today.
Okay, excellent. Thank you. Let me see if I can share my screen. Share. Screen window or tab. This one. Yes. Okay, that should be a blank screen, right?
Mm-hmm.
Okay, there you go. Do you see my slides?
Yep.
Yes.
But not my notes, right?
Correct, just your slides.
Okay, great. Okay, so good morning. Thank you so much, Drs. Conrad and Harris, inviting me to speak to you today. Also, thank you, Jean Breslin, for including this topic in VA Maine's illustrious training program. You know, I understand it's a 2-hour slot, and I'll probably be able to stay a little bit longer just because of the late start. But my plan is to speak for about, I don't know, 45, 50 minutes-ish, and hopefully leave a bit of time for some Q&A and discussion before I have to head out. Susanna, you're leading the charge thereafter, right? That's the plan?
Yes, that's right.
Fantastic. Okay. So what I wanted to do today was share a story, and it started with some pretty humble beginnings. And it organically led to the rollout of a spiritually integrated treatment psychotherapy program across really almost the entirety of McLean's 250-bed facility, which is the flagship psychiatric training facility for Harvard Medical School. And this type of work in general, and certainly Spirit in particular, would never have been possible without an incredible team of mentors, collaborators, mostly at McLean Hospital, but also around the globe. This is the short list of about 100 people, and I'm very blessed to have been able to work with people like Ken Pargament and Harold Koenig in the development of Spirit. I also want to mention the Harvard Initiative on Spirituality, Religion, and Health. And if you get bored during my talk, then check out the website, which is really a cross-Harvard initiative spanning public health, the medical school, even the business school and divinity school, of course, which are really looking at how spirituality and religion intersect with health and other aspects of wellness. So, without colleagues really institutionally championing this line of work, it would be difficult to do. I also want to mention that you're all aware that research needs funding. And for a variety of reasons, my funding has primarily been in the form of philanthropy and foundation grants. Now, there are definitely pros to having philanthropic funding. A trip to Palm Beach is not that bad. But there are also cons, because it's a lot more variable than some of the funding that's available through the VA or, of course, through the NIH. And I look forward to a day where there's more reliable, less variable funding for this work. And in the interim, I am very eternally grateful to my supporters for enabling this type of work to be done. All right, in the beginning, I started out as a McLean psychology intern in, what year was it? 2009? Yeah, 2009. And I was not here to do work on spirituality. I was here to learn how to do cognitive and dialectical behavior therapy with acute psychiatric patients. And I'm of the Orthodox Jewish faith, and I proudly wear my yarmulke to work. And the first week that I was there, a female patient came over to me in her mid-20s. And she said to me, "Excuse me, can I speak to you about God?" And I'm like, oh no, like, what do I do now? You know, I didn't want to, frankly, get into trouble. She wasn't on my caseload. She was just in the milieu of the program. And I'm not a chaplain. You know, I have my own faith and my own personal faith, but I'm there as a clinician, as a non-chaplain clinician, I should say, doing cognitive and dialectical behavior therapy. And, you know, here I am, you know, with my own religious identity being acute to this person to come to me, and she wants to talk about her life in spiritual terms, and I'm really not the right address. Like, yeah, I went to graduate school with Ken Pargament and all that, and I did my dissertation on this and research in it, but I mean, I just hadn't even finished graduate school, right? Internship's a part of graduate school. And I just wasn't the right address for her to speak to, and I felt very lucky to be at McLean, and I didn't want to mess it up. So I said to Brienne, you know, this person, we'll call her Brienne, I said to this patient, you know, you should really speak to the chaplain. And then later on that day, I found out that we actually did not have a chaplain. And this patient was on her own, and so was I. But whatever, the situation was what it was. She moved on, I moved on, and that was that. Or so I thought. Within 6 months of being there, 10 patients had come over to me. Males, females, different ages, different ethnicities, a diverse crew. And they basically had the same question. Excuse me, can I talk to you about God? Can I talk to you about my struggle? Sometimes it was a little more pointed, like, why is God doing this to me? Or, you know, why isn't spirituality talked about in my treatment? So eventually I went to my primary mentor, and I was like, I don't even know how to ask this question to him. Like, what am I going to say? So my strategy was, hey, this is what's been happening. When the next patient comes over to me and wants to speak about spirituality, what do you want me to say to them? And his ears perked up, and he said, you're right. We have to do something here, and it has to be methodical. I'm like, okay, I didn't say that, but, you know, let's roll with it. So he leaned across the desk and said, you know, we need some sort of a treatment that's going to include spirituality so that these patients actually have a place to go to address their spiritual dimensions of their care. Spiritual integrated psychotherapy, isn't this the kind of thing that you've done in the past? Like, can't you put something together, or can you put something together for our program? So I said, well, let me check, you know, and I called up Ken Pargament, and I said, is there anything we can do for acute psychiatric patients? And he's like, I'm not aware of anything. Remember, this is like 2010, early 2010, January, February. So it's like, I'm not aware of anything, but I'm sure you'll do a great job. Like, thanks a lot. Thanks, Ken. Appreciate that. Anyhow, I scoured the literature and found a little bit of work. Amy Weissman de Mamani had been doing some work with patients with schizophrenia, but they were all outpatient. There wasn't really anything in an inpatient or a residential or an intensive treatment setting. So I teamed up with one of my interns, who himself was actually an atheist, interestingly, but wanted to have some sort of, you know, aspect of diversity to service this aspect of human identity and diversity. And a very wonderful cognitive behavior therapy clinician and a specialist in depression. And we teamed up and we created a protocol. And the protocol sort of fit into the standard treatment on the unit that we were on, which is a 50-minute group session, 50-minute group session. And, you know, the beginning, middle, and an end. I'll explain more about that soon. So we drafted our therapy protocol. We went to my mentor. He looked at it. He's like, this looks great. Let's talk about it at the next staff meeting. And we did. And this is what happened. You know, people were rowing in all sorts of different directions. Actually, what would have a better illustration would be that they were like getting up out of the boat and bonking each other on the head with their oars, and some people going overboard. It was a little bit crazy of a meeting because a lot of people were concerned, and there was pushback from clinicians before they even started reading the protocol, and pointed questions like, hey, this is a tense topic. What if patients decompensate? people have different religious views? What if they are fighting with each other? You know, what if you offend people? You know, people are going to call the Joint Commission on us. If you start dealing with this issue, are psychotic patients going to be allowed? What if they have religious delusions? Is that okay? You know, is it a mandatory group? Is this voluntary? Like, how do we vet patients to come in? Are they going to be vetted by a case manager? Like, you know, practically speaking, how do we implement this in a way that's going to be positive? And I was not expecting the pushback, but some of the questions were legit. Many of them were. And, you know, my mentor stood up, Dr. Thruster Bjorgvinsson is his name, and he said, these are great questions. Let's come back at the next meeting. And we did, and addressed every single one, and said, listen, we're going to do this on a trial basis. It's going to be for 6 months. If people decompensate, we can pull the plug earlier. We're going to get data from the patients and see how they do in the group. It is not going to be a mandatory group. It will be a voluntary group. It will be pitted up against another group at the same time, which is also a voluntary group, so people will have a genuine choice. As for psychotic patients, I actually spoke with the head of psychotic disorders at McLean Hospital, a renowned international expert in the subject. And he thought that there would not necessarily be any contraindication. In fact, his position, which I thought was fascinating and turned out to be actually quite astute and true over the last many years of doing this work, was that patients who have psychosis, even if it's religious, engaging in spiritual practices could actually provide a contrast between that and their symptoms. So they're better able to bifurcate or to distinguish between this is my psychosis and this is my actual spiritual and religious identity and belief. And that bifurcation happens from approaching and engaging in spiritual practice, not by avoiding it. If we avoid it, then it becomes a cloud and it actually becomes very difficult to disentangle. But by approaching it and engaging, patients can learn to bifurcate and to distinguish between, to sort of create the Venn diagrams, right? Here's my psychosis and here's my religion. And indeed, I had not found any contraindications in the literature. Amy Weissman-Damamani said she had never had problems delivering spiritual psychotherapy, even to religiously delusional patients. In any event, we addressed these questions and got a sort of a tentative okay, like, okay, let's try this for a little bit and see what happens. So with trepidation and prayer, we started what was called the Spirituality and Cognitive Behavior Therapy group. It was placed on the weekly schedule. We started to recruit patients, and they were coming in, and I'll tell you what we did in the 50 minutes. There's a brief introduction, which talked about disclaimers. The disclaimers were simple. This group is not about converting you or anyone else. Please don't try to do that to anyone else who's here. This is about your specific spiritual experience, not somebody else's. Point number two, the main point of this group is to help you identify how spirituality is relevant to your treatment. If spiritual growth happens, and that's fine, but it's not, then the main point is to be focused on your symptoms. And another point was that people come with diverse faiths, and just to please be respectful in your language and in your approach, because it can be a complicated subject. From there, the next part of the group is an open discussion with patients, which follows the question, how is your spirituality relevant to your symptoms and treatment? How is your spirituality relevant to your symptoms and to your treatment? And often patients need redirecting, right? They'll just open up the floor and say, well, when I was 12, I used to go to, Catholic school, and kind of keep going on. And sometimes often they need to be redirected. Like, how is that relevant to your depression? How is that relevant to your psychosis, to your functional impairment, to whatever is going on? But, we engaged the entire group in a discussion about this. And then after that, the next segment of the group, we present patients with handouts. Now, the handouts have cognitive strategies and behavioral strategies that are all spiritual. And the reason we gave them handouts is because patients needed scaffolding and structure to be able to engage with spirituality, as opposed to being able to come up with it themselves. But we didn't want to say, like, do this or think this or move in this way. because it's an area of identity that people really have to select. We wanted to empower the agency of the patients by giving them a handout and saying, hey, which items on here might be of interest to you? If none of them appeal to you, does it inspire something else which you can come up with yourself? That provides enough scaffolding while giving them agency to be able to select. I call it a menu approach. It's like going to a restaurant and you pick off a menu, what you do like and what you don't like. So there's enough structure and scaffolding, but really you're the one who chooses to order whatever it is, spaghetti. And then the final part of the group is just a wrap up, and which also involved completing a questionnaire during this part of during this delivery, because we wanted to get data. So we started off with 3 or 4 patients, I think, the first week, and interest grew. In fact, at some point we actually had to go to a larger room in the unit, which I thought was kind of nice. We had good, 8, 10, 12 patients at some points showing up for these groups voluntarily, and week by week. So after a few months, we had our data, and it was time to write it up, which was really cool to do on internship. I was felt very blessed to be able to do that. So myself, Randy Auerbach, he was the CBT fellow intern. Joseph Bigda Payton was a research assistant. Dr. Bjorgmanson was my mentor, and then Dr. Lewandowski is a senior mentor, and a wonderful one at that. And this is our paper. You're welcome to look it up. It has a description of our initial group called the Spirituality and CBT group. What we reported in this paper is that over 90% of our patients had said that the groups were clinically helpful. Over 99% of our patients said that the approach was respectful of diverse religious and spiritual identities. And what was very interesting, though, and sorry, my lights just went off. What was very interesting was that 42% of our patients who self-selected and voluntarily signed up for a spirituality and cognitive behavior therapy group had no religious and spiritual faith. 42%. But the most important thing was that no one died. There were no decompensations. There were no adverse events. And the concerns that the clinical team had raised during that early meeting were essentially put to bed. This was a first foray into this, a first accomplishment, and an indication that spiritual psychotherapy can successfully be delivered to acute psychiatric patients, even in Eastern Massachusetts. So at one point during my internship, we ended up getting some limited philanthropic funding, so I extended to a postdoctoral fellowship, and then on a part-time basis for several years thereafter. I just did a bunch of research at the hospital, asking questions like, how is spirituality relevant to different aspects of depression or anxiety or psychotic symptoms or functional impairment, etc. And the reason I'm presenting some of this data here, and I'm going to go through it quickly, is because yes, this is a clinical innovation, Spirit, which I'll get to, in spiritual and psychotherapy, spirituality and CBT group that we did, but without the research that was also done, I think it would have had much more limited impact. These findings turned heads at the hospital, and it was part of the culture to identify that spirituality can be relevant to patient care. In this early study we did, we found that patients' levels of belief in God, G-O-D, a single item, ranging from not at all to very, correlated with symptom change, regardless of how it was measured. And furthermore, these effects, especially on depression, were mediated by belief that treatment would work. Patients who believed in God had more belief that treatment would be effective, more credibility and expectancies that treatment would be effective, and that mediated the relationships to greater treatment effects. Conversely, patients who had low levels of belief in God, the not at alls, only 2 of them had any reasonable level of treatment credibility and effectiveness. I'll put it this way, it's very hard to believe that treatment is going to be helpful if you're in an acute psychiatric crisis without any faith at all. More recently, we found that regardless of how you measure spirituality and religion respectively, among geriatric patients with mood disorders over the long term, religious and non-religious patients get depressed. They have depression. However, their levels of suicidality are very significantly related to various measures of spirituality and religion in a positive direction, in a buffering direction, that is, negatively correlated. So individuals with higher levels of spirituality, regardless of how it's measured, are substantially less likely to be suicidal and this was over a 3-year period. Again, speaking to the importance of faith during the times of crisis. Now, that's sort of the one main effect, if you will, that spirituality can provide and religion can provide: hope, meaning, a sense of purpose, a sense of connection, and reduce the acuity of depression and anxiety. Here's another idea, though. There's a theory which was put forth initially by Mike McCullough and others that's highlighted that spirituality is tied to greater behavioral control and suppression of impulses. If you sort of think about it, before engaging in a certain behavior, people have like a physical level, like, is this a good idea? Is it not a good idea? Like, is it going to benefit me? Is it not going to benefit me? And then if they have a spiritual and a religious lens, that's like another level. It's like another hurdle that they have to cross before engaging in a certain behavior. Is this good for me spiritually? Is this a positive thing for me in terms of my religious faith? So McCullough has a seminal paper in it was a review paper. The journal name is escaping me, on spirituality and religion and behavioral control. And we see this in healthcare, like greater compliance with medical advice, greater adherence to greater engagement with medical interventions at the end of life, sort of holding on to something and not just giving up. Now, we wanted to test this theory using a sophisticated and complex economic decision-making task. It hasn't really been tested experimentally in the past. So we used the sequential investment task to probe the effects of spirituality and religion on behavioral adaptation to positive and negative outcomes in a financial task. Basically, the task tracks how much people bet on an investment immediately after they have a loss or immediately after they have a gain. So if you bet on the stock market and it goes up, does that mean that the person's like all of a sudden betting more? Or does that not affect their behavior? If they all of a sudden have a loss, do they all of a sudden, does that change their course of betting activity, or do they stay the same? And it also tracks how consistent people are. Are they reacting to the market, or do they have an internal locus that they use in order to make decisions? So we assessed spirituality and religion with a wide range of measures, essentially 2 aspects. There was spirituality, and then there was religion. Spirituality would be like belief in the power of prayer, belief in a greater force. How important is spirituality to you? Religion would be like attending religious services, involvement in a religious community, frequency of private religious activity. How important is religion to you? And essentially, religion, but not spirituality, was associated with greater consistency in decision-making, less behavioral change resulting from gains and losses. And that was essentially the finding. And what the suggestion is from an empirical standpoint is that religion can help buffer against certain aspects of impulsivity. You all know, though, that spirituality is not always positive. And when it comes to the negative aspects of spirituality, spiritual struggles, these can be extraordinarily pernicious in acute psychiatric samples. This is just one study. I could go on for a whole hour on spiritual struggles in acute psychiatric patients. But in one of our studies, a telling one, we were able to account for nearly 50% of the variance in patients' suicidality at intake simply by a 4-item measure of spiritual struggles. An incredible amount of variance. when patients are questioning, what's the meaning of life? Why is God punishing me? What did I do to deserve this? Those are not simply cognitions. I mean, they are, but they have such powerful meaning that they can drive people beyond the brink during acute times. This even has some potentially can be mediated by certain neural processes. This is a paper that Caroline and I are working on right now with Purnima Kumar and a couple other folks from the Brain Imaging Center here at McLean, that essentially this is among older adults. In resting state fMRI, spiritual struggles seem to be associated with greater connectivity in the insular region, which means that the insula goes online or offline together. When people are struggling with their faith, they're much more reactive to negative outcomes. That seems to be, and this is an early study with the preliminary and a small sample. It's 32 older adults, but nevertheless, we're seeing some correlations and hopefully writing us up. Caroline, this week we got to get that paper out. Okay, the most important findings though that we had, the most important, were actually the simplest. At one point, I just sampled the patients at McLean. I said, well, how many of you are religiously affiliated or have belief in God or believe that religion is important or pray on a weekly basis? I couldn't believe it. I could not believe it. How many patients wanted, not even wanted, how many patients had spiritual faith? This is, remember, keep in mind, this is Eastern Massachusetts. Like you folks are in Maine, so it's a similar climate. But we're not talking about Memphis, Tennessee. I mean, you know, this ain't the Bible Belt. 80% of our patients praying on a weekly basis, 60% having religious affiliation, 70% having high levels of belief in God, and nearly half going to services on a weekly basis. I mean, this is telling. Furthermore, who wants spiritual psychotherapy? Like, how much? So before we did this study, we took bets. Dr. Bjorgvinsson thought maybe it'd be 10% of our patients, which, by the way, would still be a substantial number. Still be 500-600 patients a year at McLean, more. Others in the research team thought maybe 15%. I thought, okay, I think it's 25%. But none of us predicted that more than 50% of our patients would want fairly, moderately, or very much interest in spiritual psychotherapy. But what was really fascinating is that 37% of those patients who have substantial interest in spiritual psychotherapy have no religious affiliation. When we ask patients, is there a religion that you affiliate with? It tells us almost nothing about whether they want to have spirituality as a part of their care. And furthermore, spiritual psychotherapy is a process that is important to patients almost irrespective of their faith. So this body of research turned heads at the hospital and also with donors. And in 2014, 15, the hospital created a spirituality and mental health program, and I got to be its director, which is pretty cool. And I started getting calls from the clinical units saying, hey, can you develop a treatment that we can use in our program here? You know, our groups aren't 50 minutes, they're 30 minutes, or ours are 60 minutes, or whatever it was. And McLean's a great place. We have specialized units just for depression, just for anxiety, just for OCD, just for psychosis. Yes, there are general units as well. Just for eating disorders, though, there's lots of specialty. As a specialty hospital, there's lots of specialized care, subspecialized care. And soon after that, we got funding from the Bridges Consortium, which is a grant competition which is administered by Brigham Young, and the John Templeton Foundation funded it to advance research training and clinical innovation in spiritual integrated psychotherapy. And what we did is took the opportunity to revise our spirituality and CBT protocol to have a more flexible approach. And the flexible approach could account for inpatient, so sort of acute, really high acute treatment, residential, sort of more lower security, so to speak, and then intensive, like a PHP program, which is where we started out. And that was the birth of SPIRIT, Spiritual Psychotherapy for Inpatient, Residential, and Intensive Treatment. We really lucked out with that acronym. We ended up publishing this paper, which you'll see, you can take a screenshot of it if you want. This is fully available in the public domain. We negotiated with the American Psychiatric Association to make this available in full text in open access. And our clinical protocol is actually included in this psychotherapy tool paper. So the treatment is very similar to what we did previously. We start off with that question after the disclaimers. We start off with the question, how is your spirituality relevant to your mental health? And then what we did is we developed more than just 1 or 2 handouts. We developed 7. And the clinicians have a choice which one of these handouts to use. So if the theme of forgiveness comes up in the initial part 1, where people are talking about that group discussion, facilitated discussion of how is your spirituality relevant to your treatment and relevant to your mental health, they might pull handout number 7. If the concept of prayer came up in spades, well, then they might pull handout number 6. If a lot of patients are struggling with their faith in different ways, handout number 3 is the way to go. And so on and so forth. And we recruited nearly 24 clinicians from across McLean Hospital, different levels of training, different levels of spiritual and religious affiliation, to be able to participate in the study. And these dedicated, open-minded, and wonderful clinicians really get the credit for the project, because it would not have happened without them. We also recruited a ton of patients. Nearly 1,500 patients participated in this study on different units. And again, there you see all the specific subspecialty conditions, whether it's substance abuse, post-traumatic stress disorder, psychotic disorders, as well as the general units. And this was over a 15-month period, which ended in April 2019, 10 years after I started at McLean. Now, some of the patients came more than once to a group. In the residential settings, sometimes patients would be there for 2 months and longer. So those patients, the group leader had a decision to make: do I use a different handout this week or not, depending on the constitution of the group, and it was entirely up to the clinician. In an intensive, partial, or inpatient unit, usually they only attended once. But we actually logged 3,400 visits to spirit groups. In our analyses, though, we only coded the first engagement with a spirit group for each unique patient. So 1,468 is the unique patient visits, even though we had nearly 2,000 surveys from 3,400 visits. As you can see, I'm not going to go through all the details here, but as you can see, a very diverse group religiously and diagnostically. And what you'll see here, which I'm going to point out, is that those with none or spiritual without religious affiliation are the largest group in combination from anybody else in this cohort of self-selecting patients for spiritual psychotherapy. Okay? You're more likely to have no affiliation at all, even than to be Catholic, in terms of self-referring to a spirit group. By the way, the number is about 40%, which is exactly what we found the first time. About 40% of our patients were non-religious, and it's about what we found when we did the study that we published in JCCP that I showed you the slide of before. 37% was the number over there. So I think it's a reliable statistic over 10 years, multiple, now it's 3 data points. About 40% of patients who are self-referring to spiritual psychotherapy have no religious affiliation. And interestingly, they do pretty well, as I'll share shortly. The main results of this paper were, of the study rather, were that the vast majority of patients reported that spirit was helpful to them, and that it helped them to identify spiritual and religious resources to be able to use to reduce their distress and to help them in their care. Now, we published a second paper, also in the American Psychiatric Association Journal of Psychiatric Services. What are the predictors of that? Which patients do better in spirit compared to others? And furthermore, we had nested data. So the clinicians, we knew information about the clinicians, and we also knew which aspects of care, which handouts were used at each session by the clinicians. So all that data was nested with the patients. So we knew which patients were benefiting, so to speak, to what extent from treatment delivered by the specific clinician with the specific intervention. So it was a really great data set to be able to use, and we published, Caroline, how many is it? Like 5 papers at this point? I think it's 4 or 5 papers that have come out of it. Anyhow, this is the second one. And just taking you through the study, the results briefly, demographic factors, interestingly, were not associated with better outcomes in Spirit. Now, there's a misnomer that a lot of people have, which is that older adults benefit more from spiritual psychotherapy, and that spirituality and religion are more relevant to the mental health of older adults than younger adults. In fact, my program, Spirituality and Mental Health Program, is housed within the geriatric psychiatry division at McLean Hospital for this reason. It was understood, or thought, I should say, it was thought to be the case 10 years ago, that this is a dimension of life that would be more specific to geriatric populations, to individuals at least 55 plus, maybe 65 plus. In all of the studies that I have done at McLean, in anything I have published, I have never seen age be correlated with our outcomes. And in Spirit, it was no exception. Age of the patients was not associated, whether you divided it at 55 plus and bifurcated your sample, or whether you looked at the entire continuity, if you looked at it as a continuous variable across the entire sample, age was not associated with greater response among patients. Same with gender, race, disability, whether patients were college students, diagnostically, no differences. Whether it's even the severity, like if they're on antipsychotic medications or using ECT, or the type of diagnoses they have, none of these were factors. And that's a great indicator, I think, that Spirit can be delivered to a complex patient population across a mental health hospital, irrespective of basic clinical and demographic factors. This is a paper that Eleanor Schutenberg, one of my former RAs, published, which is also in an American Psychiatric Association journal. And she looked at sexual minorities in our sample and found no differences between individuals who identified as sexual minority and otherwise in terms of spiritual psychotherapy. I will add, anecdotally, there are so many patients who are sexual minorities for whom spirituality and religion are an important factor, either through spiritual struggles and through concerns that they've had dealing with aggressions and dealing with bias and discrimination within religious communities, or otherwise, and positive factors as well. The fact that there's, spirituality can be a beacon of hope. It can help buffer against impulsivity and impulsive decision making. And this vulnerable population is deserving of spiritual psychotherapy like anybody else. So this is one paper on that. We also looked at spiritual and religious characteristics of the patients. And here we found significant effects because we had such a large sample with 1,500 patients. 1,468 patients, you're going to find it. However, when we looked at unaffiliated patients as a group of themselves, that 40% of the sample, the numbers reporting some benefit were still 80% of those samples, 80% of those patients. Furthermore, the mean score for having no religion was greater than 2.2. In other words, the average level of spirituality, of religious affiliation in the sample was somewhere between fairly and moderately on that 5-point scale that we used. The scale is 0 to 4, so it's a 2.2 on the 0 to 4 scale. So we're not talking about a predominantly religious sample overall here. So if you look at it, the big picture, spirituality and religion seem to be associated with somewhat better response to spirit, but nevertheless, this is clearly a deliverable service to individuals with no religious affiliation. Another important thing, I mentioned the nested data, clinician factors. So clinicians who were religious versus non-religious, we found a very significant difference. Age was also associated, but if you control for age, the clinician religious affiliation is still significant. If you control for religious affiliation, age is not significant. And age was associated positively with religious affiliation. So basically the age is a artifact of clinician religious affiliation. After that mouthful, here's the result. Unaffiliated clinicians clinicians with no religious affiliation at all had statistically significantly better results among their patients when delivering spirit than religiously affiliated clinicians. Now, interestingly, this is not related to treatment matching. We looked, is this associated with religious patients matched with religious versus non-religious clinicians? It has nothing to do with that. If you control for religion among the patients, this effect remains. So this is a very unexpected finding, although it had been found once or twice in the literature beforehand. If we have time during Q&A, I can get into that. But since we were surprised by it, we actually published a second paper, third paper, I guess. Actually, this is number 4. Our fourth paper in Psychotherapy, which is American Psychological Association journal, on why is this? What was the reason why spirit had more effectiveness when being provided by non-religious clinicians? And the bottom line is that non-religious clinicians, and the reason I'm bringing this out is because it's important for all of us. Non-religious clinicians who provide spiritual psychotherapy are more likely to use dialectical behavior therapy techniques and an approach than cognitive behavior therapy when delivering the treatment. In very broad brushstrokes, CBT is about don't think this way, think this way. Don't do this, and you will change. It's directive. Yes, it's collaborative, but it's directive. It's more, hey, this is what we have to do. It's more prescriptive. DBT, on the other hand, balances change, like CBT, with acceptance. We have to accept where we are right now, and change might not be possible. Yet, we simultaneously move towards and evolve towards changing in the way that we can. And we have to adapt our strategies to where we are in the cycle. At certain points, change is going to be very hard. At other points, we might be able to run ahead. And we have to respect both and balance change and acceptance. If you think about it, a non-religious clinician signing up to participate in the spirit study has to be pretty balanced as a person to be able to say, hey, there's change on the one hand, and then there's also acceptance. And this is sort of, it kind of goes with the territory, being more mindful, being more aware, being more centered, and that comes out in the delivery of the treatment. Religious clinicians providing spirit, I think, are more likely to be like, hey, this is what we got to do, and then we will move forward. And when providing that, especially to acute psychiatric patients, I don't think it's the right approach. I think we have to be much more DBT focused, generally speaking, in providing any treatment to acute psychiatric patients, but certainly spirituality. All right, so a lot of people ask me, like, where are we going next? What is this? What are the next steps in this research? So we actually just received some funding to create a more formal training program in spirit. The way we trained our initial cohort of the 22 clinicians was pretty informal. I sent them the protocol. I met with them maybe 30 minutes. If they had any questions, they could call me up. I mean, my office phone is like literally right here. They got my extension. But if we're going to leverage this and get it out to the world beyond McLean, beyond our, our teaching hospital, as sizable as it is, it's still, just one corner of the universe. We really need to have a formal training program in how to help people do spirit. And that's what we have funding for from the Spirituality and Spiritual and Religious Competencies Project, SRCP, also funded by John Templeton. And the goal is to be able to expand beyond McLean. Now, let me just see if this video link works. No. Okay. The first part, the sound of it is like a little quiet. So give it like 30 seconds before you can maybe hear the audio. Can you hear the audio? Hello?
There's a box you need to click that says include audio when you sign into Teams. So you may need to sign out and back in and make sure you click that box.
I'm not going to do that. Okay, so basically, I'll show you afterwards a link to my website, and if you want, you can go and check out this video. Okay. But anyhow, that's one of our projects. Here's another one, and I have another video for this, but you're not going to see this, which is called Digital Soul. Digital Soul is a, as the screen says, non-denominational approach designed for patients to explore how spirituality might be relevant to their mental health. And essentially, this is the Spirit protocol digitized. It's cute. It's got cartoons. I had an awesome research assistant the last couple of years, now going to be Dr. Sean Mins. He's now at USC in graduate school, a real star in this area, who programmed the app soup to nuts. I kid you not. He did an amazing job with it, deployed it, and we recruited, Caroline, 150 patients?
No, 230.
Oh, wow. Okay, I got to take a look at the data. So this was fun. And what's really cool about Digital Soul is that you don't have to train clinicians at all. So the potential for deployment here is actually quite substantial, but it's still a very early stage project, and things move very fast in the area of digital psychiatry. Unfortunately, we have an Institute for Technology and Psychiatry right here at McLean, and very well-supported group, and I'm very fortunate to be able to collaborate with them on this as well. Another next step for this is how to tailor Spirit. You know, Spirit was designed for all patients, but there are specific groups of patients. And my wonderful research fellow, who you just heard from a second ago, Dr. Caroline Kaufman, is doing some really fascinating work on first responders, police, firefighters, paramedics, corrections officers, etc. Now, this specific group of patients, firstly, highly likely to have post-traumatic stress and also alcohol misuse, and also highly likely to have spiritual and religious identity, and also very likely to not engage in traditional forms of treatment. So the provision of spiritually integrated treatment to this vulnerable and important population is a unique and important public service. And the adaptation of Spirit to first responders who have comorbid alcohol use and post-traumatic stress disorder is something that Caroline is working on. And she was recently awarded some pilot funding from John Templeton to create a single session Spirit protocol for first responders. She's also done some qualitative work and some other basic quantitative work looking at the intersection of PTSD, alcohol misuse, and spirituality in this population. All right, this is our lab website, spirit.mclean.harvard.edu. Both of those videos are up there, so please go take a look. It's under project, and we are very happy to welcome you to our site. Okay, I'll make a couple concluding remarks, and I'm at like 47 minutes, so right on time. Now, does anyone know what this is a picture of? If you've heard me speak before and seen this slide, then please don't answer. Okay, so the answer is, it is the most widely utilized mental health service in the world today. A mental health service, yes. When it comes to alcohol and substance abuse, it's understood that spirituality should be a part of treatment. This is the annual convention of Alcoholics Anonymous. Massive, massive. It dwarfs anything else in the mental health space. But in the rest of psychiatry, it's very uncommon. A talk like this at a VA to interns, I don't know, how many a year do I get? Maybe 2? You know, our experience at McLean suggests that we really have to be more open to this topic, irrespective of diagnosis. But I will suggest something further. If you look at psychiatry, if you look at mental health treatments, we have great answers to mental health problems. The biggest issue is that people don't come. Yes, stigma is down over the last couple of years, post-COVID. Yes, referrals are up. However, it's still the number of people suffering versus the number of people who go and get treatment. You can't compare. Dissemination and implementation are still our number 1/2 concerns as a field. When it comes to spirituality, that is not a problem. Patients will come up to you in the hallway and say, hey, can I speak to you about this? There is a natural, I believe, natural drive inside of many people to seek out spirituality, especially during dark times, during challenging emotional times. In many ways, this is the oldest trick in the book in mental health. And when we use it, we see that dissemination and implementation can be advanced by leaps and bounds. So to that end, I thank you for the opportunity to speak to you today, and I'll be very happy to entertain any questions and comments. Thank you.
Thank you for that presentation. It was really helpful, I think, for our trainees to see that people who don't have